Hi everybody, this is Penny, and I'm going to take this opportunity to review diabetes content. As I was reviewing the learning objectives for Learning Plan 7, Endocrine, in our course, CHA 1, I see it does ask us to review the content that you have already received in Health Alterations. So I would really appreciate it if you'd pull out your notes from Health Alterations and review your diabetes content. Along with that, Chapter 67 of your IGGY book does a real nice job of care of the patients with diabetes mellitus. So I'm going to just do a very quick overview of that. And if you have any questions, just give me a call and let me know. Okay, so as you know, diabetes is a very prevalent condition in our society. It afflicts about 1 in 20 persons in the Western society, which we're a part of. Most aged 40 or older, but type 1 diabetes does occur in those aged less than 5. And as you may be aware, type 2 diabetes, which is a non-insulin dependent, for the most part, actually is beginning to occur more and more often with juveniles as well. Approximately 500,000 cases are diagnosed annually in the hospital. Frequently they are termed new diagnosed diabetes, so you're aware that they are actually newly diagnosed. A statistic from 1990, interestingly, it said that 7 million people knew they had diabetes. Ended up that the equal number actually had the disease that were undiagnosed at that time. In general, diabetes does affect women and Black people about twice as frequently as white males. The Latino population, which we need to consider, is approximately 1 in 5, and in the American Indian population is reported it may be as high as 1 in 2. And I know from my own experience from a trip out west, perhaps about 5 years ago, an American Indian tribe, it was almost 100% diabetes type 2 were afflicted. This slide here demonstrates the enormous economic influence that diabetes has had on our society. As you can see, it accounts for as much as 1/5 of the money spent in healthcare dollars. And I hope you're aware as you progress through your clinical rotations of the effect that diabetes has, whether it's the newly diagnosed client or those suffering from non-healing wounds or other things that are really very much connected to the initial diagnosis of diabetes. So keep that in mind when you consider the effect that it has upon the healthcare system and our economy. As you know, there are 2 major types of diabetes mellitus, type 1 and type 2. Type 1 is characterized by actual beta cell destruction. Beta cells reside in the islet of Langerhans in the pancreas. I'm sure you recall reading about that. It can either be autoimmune or more often idiopathic in nature, meaning there is really no linked cause for the disease. However, the result of both of them, autoimmune or idiopathic, is that there is no insulin production from the pancreas. And in type 2 diabetes, as you may recall, it can result from a couple of things. Firstly, it could result from actual insulin deficiency, where the pancreas isn't producing and secreting enough insulin to meet the body's needs. Or it could result from actual cellular resistance to insulin, where the body requires more insulin to transport that glucose into the cells. Many times these 2 processes happen simultaneously. A quick word here about insulin. It's actually an interesting substance. It's protein made of 51 amino acids. And these amino acids are actually converted by the beta cells in the pancreas into insulin and a byproduct of a C-peptide chain. Now that C-peptide chain, or the levels, can actually be measured and indicate the rate at which the beta cells are secreting insulin. That's why we frequently measure the hemoglobin A1C. We're looking at the actual production of insulin or secretion of insulin. This slide is an attempt to demonstrate how the body releases insulin in a regular pattern. It has a basal rate where it releases it, say, at nighttime at a very low level, maybe 2-3 units per hour from the pancreas. But at breakfast, lunch, and supper, when the person is eating, when their glucose levels tend to spike, the pancreas will naturally release more insulin in response. This chart here just demonstrates the diabetic range before and after meals for desired glucose levels. I think this is really important to know that before a meal, the desired diabetic range is between 70 and 130. And after meals, the very highest it should get is less than 180, so 179 or below. This slide simply demonstrates the basic breakdown of glucose into glycogen via the liver and muscles, or triglycerides in the fat cells. There are counter-regulatory hormones to actually balance the insulin production. For instance, if the blood sugar gets too low from insulin overproduction or perhaps not enough glucose intake, the liver can release glucagon, which converts stored energy into glucose. Other hormones there are listed: epinephrine, norepinephrine, growth hormone, and cortisol are also counter-regulatory hormones to insulin and provides that balance. 3 of the acute complications I'll be covering in this presentation are hypoglycemia, DKA, which we have looked at already in our acid-base learning plan, and HHNS, which is a hyperglycemia, hyperosmolar non-ketotic syndrome. Again, I realize this is review from second semester, so I absolutely encourage you to get out your notes from Health Alterations and follow along. As far as hypoglycemia is concerned, it is simply defined by a low blood sugar. Latest data supports less than 65. I'm sorry, it says greater than 65. It should say less than 65. And it is characterized by signs and symptoms of low blood sugar, which are probably very familiar by now: shakiness, tremors, sweating, tachycardia. I'll let you read through those. What sticks out to me the most in that paragraph is behavior change, confusion. So many times when their blood sugar is low, because of these manifestations, it can be difficult for them to take action on their own behalf. So it's important for us as providers to know the signs and symptoms of hypoglycemia. Okay, so treatment for hypoglycemia. As far as nursing actions are concerned, usually in the hospital there'll be standing orders, and you'll get the blood sugar result and you'll refer to the MAR or to your standing orders and know what actions to take. As far as home care or home teaching goes, not only do you need to instruct the client how and when to take their blood sugar, but also that if they are low, about what actions to take, and that would include eating or drinking about 15 to 30 grams of carbohydrates. It has been a common mistake in the past, from nursing anyhow, to overcompensate for low blood sugars. I recall, even in my own practice, when clients would have a low blood sugar, say of 52 or even 40 something, that we'd bring in a glass of orange juice with a couple of sugars in it, and we'd bring in a second orange juice with a couple of sugars in it, and of course then they'd rebound way too high. Now providers are more specific about only providing about 15 to 30 grams of carbs. Then you would recheck the blood sugar in about 15 minutes and repeat the carbohydrates if necessary. So all of that is really indicated in discharge teaching. Some doctors or providers are now advocating for a protein source to go along with the carbohydrate to help sustain the blood sugar. Many facilities have diabetic educators that come to the client's room. They can give them this education, but I suspect there are some, especially in the rural areas, that do not have diabetic educators. So you will need to know how to respond to your client's educational needs. Now, if the client would be unconscious, you would have to, of course, instruct the family to call 911 or to administer glucagon tablets if they're able to do that. Your textbook IGGY describes diabetic ketoacidosis as being caused by a total or partial lack of insulin combined with the action of counter-regulatory mechanisms or hormones. And there's a nice diagram of that in your text. It also indicates that it usually starts with an infection or a stressful event, which actually gets those counter-regulatory hormones functioning. And it is a sudden onset characterized by blood sugars greater than 300, and many times it can be much higher than 300. Now, as we have already gone through in a previous learning plan, it is characterized by metabolic acidosis. So the pH would be what? Elevated or decreased? Of course, in this case, the pH would be less than 7.35. In metabolic acidosis, the bicarbonate would be elevated or decreased. And of course, because bicarbonate is a base and this is acidosis, it would be decreased. Potassium, which is common denominator of acidosis, would be normal, but many times elevated just because of the acidosis. And I've listed BUN and creatinine here. These people typically are very dehydrated, so their BUN and creatinine will be elevated. And as far as urine ketones, that will be positive as well. So as you go through this slide and fill in those blanks, make sure you understand why those values are either elevated or depressed. Okay, so with diabetic ketoacidosis, there's a lack of, or absence even, of insulin. And if you recall, insulin is sort of the key that opens the door of the cell to glucose. So without insulin in the bloodstream, the glucose will go up. Glucose is a large molecule that poses a lot of osmotic pressure, so it pulls a lot of fluid into the vascular space. Because of that, the client will have polyuria, or a large urine output. And if they have a large urine output, naturally they will experience thirst and have polydipsia, which is increased thirst, and polyphagia, because they have increased metabolic needs. All in all, this cycle leads to dehydration and actual hemoconcentration, where some blood values may appear falsely elevated. hypovolemia along with that dehydration, thick blood or hyperviscosity, decreased perfusion or hypoperfusion, which leads to tissue starvation of oxygenated blood or hypoxia. Here's a quick review of the carbonic anhydrase formula related to diabetic ketoacidosis. And if you don't remember this or remember how that buffer system works, go back and review this. There is going to be an increase in ketone bodies or ketone production and an increase in hydrogen ion or hydrogen ion excess, and that's why the acidosis results. So metabolic acidosis, as with respiratory acidosis, will end up with electrolyte abnormalities, specifically hyperkalemia or a high potassium level. Compensation is respiratory, so if you recall what's going to happen, usually the autonomic system takes over and the client will display Kussmaul respirations, which are very rapid and deep respirations to exhale some of the excess acid or hydrogen ions. So, as this client is hospitalized, some of your goals as a nurse will be to restore the body fluids, to reverse dehydration, decrease blood sugar to the normal range, and get the electrolytes within normal limits, especially the potassium. And here's a list of some of the potential nursing diagnoses associated with diabetic ketoacidosis. Okay, and a quick word about HHNK, which is the hyperglycemic, hyperosmolar, non-ketotic syndrome. This has much more of a gradual onset than DKA. It is also characterized by stressful episodes or perhaps an infection, or as the slide indicates, poor fluid intake. And so there is many times a factor that will stimulate HHNK. Many times there are altered neurological systems involved, for instance, a decreased thirst perception. And many of the other symptoms are similar to diabetic ketoacidosis. What I would like you to know is that HHNK is characterized by a very high glucose level, greater than 800. I think your book says generally greater than 600, but many times it's even higher than that. The pH will be elevated as to the DKA, which is acidotic or low. Bicarb may be elevated. Now the serum sodium and potassium could actually be normal or even low in this case. The BUN and creatinine will be elevated as with diabetic ketoacidosis, so those will be elevated, and primarily because of the dehydration, just as with DKA. However, a distinguishing factor here is that the urine ketones will actually be negative, whereas with diabetic ketoacidosis, they were positive. So why there's no ketones is that there's just enough insulin present to prevent ketosis, but still the client will demonstrate symptoms of hyperglycemia. Other symptoms of HHNK are similar to DKA, but I would like you to know that after a while, because of the dehydration and decreased blood volume, the kidneys actually reduce glomerular filtration, and this causes the glucose level to further increase, and the diuresis will decrease because of the kidney involvement there. So you'll see marked dehydration, and the electrolytes will be affected as well. I found interesting the box in IGGI that talks about consideration for older adults with HHNK. And it says that mortality rates in older patients are as high as 40 to 70%. And many of these clients are of those who did not even know that they had diabetes. So I guess it's just a red flag for us to really screen our elderly clients a little more closely. Okay, this is a little more detail on signs and symptoms of the HHNK. Again, a review from Health Alterations that I was just reading. Dry mucous membranes, skin turgor is poor, of course. You'll see tenting from dehydration. There will be oliguria or anuria, which is absence of urine output. If the renal function is impaired, you could actually see signs of third spacing, such as edema around the eyes and dependent edema in the limbs, increased abdominal girth. In that case, you may see increased blood pressure, bounding pulses, jugular vein distension. If it's dehydration, you will see changes in blood pressure with movement or with repositioning, orthostatic changes. Make sure to check their blood pressure at rest and when they sit up. I think that's really important to do before you actually get the patient in the upright position. Change the level of consciousness certainly can occur, and of course, high blood sugar is a defining characteristic. Here are some top priority assessments or interventions for a hospitalized client with this condition. Teaching for a client hospitalized with HH&K is very similar to diabetic ketoacidosis as far as monitoring blood sugars and knowing what signs and symptoms to watch for and what to report. These next few slides look at some of the long-term effects of diabetes, including the various types of complications. We'll go through these pretty rapidly. This is a review from previous slides, but greater than 2 million Americans are hospitalized each year because of diabetes-related disorders. And I'll just let you read through these about the effects they have on the vision, renal function, skin integrity, and heart disease. And interestingly, I felt the statement from diabetes website that I've quoted below here says it is now certain that appropriate treatment of diabetes can retard, if not prevent, some of these complications. And this is education that's getting out with juvenile diabetics, type 1 diabetes, as well as early onset type 2 diabetes. It's so important for us to advocate for these clients to check their blood sugars frequently and really to keep a tight control of their blood sugar to prevent these complications. Okay, so I'd like to discuss some of the long-term effects of diabetes. And what I'd ask you to do is add a word here. I meant to write microvascular and macrovascular diseases. So we're just going to consider both of them right now. And Iggy does a nice job of reviewing them, and I know you've talked about this in Health Alterations. But if you recall, cardiovascular disease is probably the #1 complication of diabetes, and it is considered a macrovascular disease, as is the cerebrovascular disease or disorders. Some of the microvascular diseases are those affecting the eyes, diabetic retinopathy or aneurysms in the vessels, diabetic neuropathy, and kidney involvement, nephropathy. So one of the microvascular changes are associated with a change of the basement membrane of the vessels in the retina. And your book discusses that legal blindness is 25 times more common in patients with diabetes. And it is also associated with the length of diabetes. So the longer the person is diagnosed, the more chance they will have microvascular changes, which of course makes a person think that those affected by type 1 diabetes as opposed to type 2 would be more at risk for developing this sooner. Okay, kidney damage or nephropathy is another complication of diabetes. Diabetes is a #1 cause of kidney damage. And those at risk for kidney damage are those who have had diabetes for an extended period of time. One of the major symptoms or signs of kidney damage is protein or albumin in the urine. When their urinalysis comes back that is positive for protein, where albumin is called microalbuminuria, then you know there has been some actual damage to the glomerulus or to the kidney, and they are at risk for kidney damage. Okay, so diabetic neuropathy is a sign or symptom that we often see in clients who have experienced diabetes. Basically, because of the hyperglycemia and damage to the blood vessels, there is a lack of oxygen or ischemia to the nerves. And that results in a lack of sensation or altered sensation. It is very important as we are assessing our clients that if they are experiencing neuropathy or lack of feeling, especially in their feet or in their hands, that we do a thorough assessment of any skin disorders or break in skin integrity that may be present. Frequently a client who is admitted with diabetes who has severe peripheral neuropathy may not even be aware of an open wound or just an area of redness, in an area where they can't see it, say under their foot or between their toes. So make sure you do a thorough skin assessment. As far as foot care, going a little further on that, make sure you assess the feet very well. Diabetic clients are at risk for a hammer toe or a bunion, which are actually malformation of the bone and soft tissue structures. Checking footwear for areas that rub or pressure on foot areas will cause ulcers. In the past, I've actually had a patient stand on a piece of paper with just socks on, and I've drawn a line around their foot. Then I have them put their shoe on, and I'll have them stand on top of their foot outline on the piece of paper and draw a line around their shoe and see if their shoe is actually compressing any of their foot tissue, and more often than not it is. And these people who have peripheral neuropathy are very much at risk for skin breakdown, so it's important that their shoes fit well. As far as client teaching, they should check inside their footwear before putting on and make sure there's nothing that will cause a breakdown. They should keep their feet clean, wear shoes that are not only large enough but have a good structure to them and support, and nail care. Many times a podiatrist will be consulted to do nail care on these clients. These next couple of slides are going to highlight some of the major categories of oral anti-diabetic agents that you may have given or may be given in clinical. The first is sulfonylurea agents. I guess the most important thing to know about this is that it actually stimulates release of insulin from the pancreas. So a person with type 1 diabetes would not be a good candidate for this medication. As far as the biguanides, the distinction here with this medication is it actually decreases the cellular resistance to insulin, so it will take less of the client's insulin to facilitate transport of that glucose molecule into the cell. So it in itself will not cause hypoglycemia, only if it's taken with insulin or perhaps a sulfonylureic agent. Okay, then quickly two more categories of oral anti-diabetic agents. The first is alpha glucosidase inhibitors. Basically, it just slows down the absorptions of carbohydrates. So that way it allows for a more steady absorption of glucose into the cells. And basically, there's a lot of side effects associated with this, and most of them are the GI category. And this category of medication actually results in no hypoglycemia, also unless it's used with sulfonylureas and insulin, because it's really only affecting the carbohydrate metabolism and absorption. Finally, the thiazolidinides actually enhance the insulin action in the tissues. It makes the tissues more sensitive to insulin. So many times it'll be used with the sulfonylureas, which cause, again, increased secretion of insulin from the pancreas. So it makes for a nice combination. It can cause some issues in the liver, so they will usually do the liver function test first to make sure that's normal, and throughout treatment. And I've listed some common side effects there. Okay, so I'd like to just address a couple of insulin delivery systems. I'm not sure if you had this in health alterations, but as you know from work in your prior areas of occupation or in the clinical settings, that insulin pens are certainly very common and very handy. They're now applicable for both long and short-acting insulins. They're very easy to use for patients. The needle application is easy. Pretty much just involves cleaning the hub with alcohol and putting a new needle on with each use. Once the client determines how many units of insulin they need, the dosaging is accurate. Usually involves purging a small amount and then twisting the bottom of the pen until you get the desired number. And the numbers are large and sometimes even magnified. So if your client has retinopathy, it's much more easy to use than the small syringes and drawing up out of a vial. So I understand that insulin pens can sometimes be more expensive, so there may be a financial aspect to this, but I'm not real clear on that effect at this point. Okay, just a brief word about insulin pumps, which I really think is going to be the wave of the future. There are a lot of advantages to insulin pumps. There's much tighter control of glucose levels, more food freedom for the client. They're able actually to turn on or off the pump or give themselves a bolus as needed. So, for instance, if they turn off the pump and there's no insulin being delivered, might be appropriate if they are going to experience exercise. Otherwise, a client who's going to be experiencing exercise may take extra glucose ahead of time, whereas this person on a pump may just turn it off. There are less chances of long-term complications simply because the control of the blood sugar is a little more tight. There are certainly disadvantages to insulin pumps, including the extensive education and follow-up that's necessitated. They need to check their blood sugars more frequently, and it has been demonstrated in lots of research that the more frequently a person checks their blood sugar, the better control they'll have of their blood sugar and the less complications they'll have. So maybe this is actually an advantage that they need to check their blood sugar more frequently. But with the insulin pump, it is necessitated. With the insulin pump, it is a device that's embedded in the subcutaneous tissue and held against the abdomen or the chest or whatever it's implanted. And that site does have to be changed about every 3 days. So there is, of course, a chance of infection with that. Here I've noted that the client, in case there is unbalanced blood sugars, a client isn't being vigilant with checking their blood sugars frequently, they could have chances of complications, including ketoacidosis. And of course, because it is a pump, and it is a mechanical device, there is a chance of malfunction of the pump and hypoglycemia in that case, or hyperglycemia could result depending on how the pump malfunctioned. Here's a picture of one type of insulin pump. As you can see, the client is holding the module itself, and it's attached to a catheter, which at the very end is attached to a subcutaneous needle that is implanted in the client subcutaneously, probably covered with a transparent dressing. And again, they're good for about 3 days, and at that point the client would have to change sites. Okay, and here is kind of a wish list of new and upcoming treatments for diabetes. The first one I've listed here is pancreas transplant, which has been done successfully, but again, just a very new treatment modality. And actually what I've seen a little bit more often than that is beta cell transplants, where they'll take beta cells from a donor or cadaver and implant them in a client's liver. And that has been done with some success. And not on the market yet or include things such as inhaled insulin or transdermal insulin. But wouldn't that be quite the breakthrough in medical technology? Okay, just wanted to take a moment to describe the ADA recommendation for nutrition for a client with diabetes. It's not a whole lot unlike any client. Just keep in mind that the protein should be a good amount, 15 to 20%. Fat, up to 20%. However, you really have to teach clients how to read a label and to discriminate between saturated and unsaturated fat, whereas only about 10% of their dietary intake should come from saturated fat. 60% from either carbohydrates or monounsaturated fats. So encourage your client to have a diet high in fiber. They really need to know how to do carbohydrate counting. There are a lot of sources for carb counting. I was looking online, and actually Barnes & Noble and even Walmart have several sources for teaching basic carbohydrate counting. If they do have protein or albumin in their urine, they'll probably have to decrease their protein down to about 10%. That'll be based upon their lab values. Okay, as you know, exercise is very important in our daily regimen. For diabetics in particular, it improves carbohydrate metabolism and insulin sensitivity at the cellular level. Improves a sense of well-being. Motivation can be difficult, especially the diabetic who has to monitor their blood sugars. And let's face it, activity or exercise can make those blood sugars pretty labile. They tend to become hypoglycemic with exercise, so they need, it has to be regular, predictable exercise with moderate intensity. Many times clients will take their blood sugar before episode of activity, especially say if they're adolescent, involved in sports or something that's during a rapid growth period, and they can take a carbohydrate source before that activity. I'll just let you read through the rest about the effects of exercise on diabetics. Here's kind of an important point for diabetics who are planning to exercise. They obviously should check their blood sugar beforehand. Now, if their blood sugar is greater than 250, they should check their urine for ketones. If it is positive for ketones, then that means they're burning fat and they should not be exercising. If they have administered insulin, they shouldn't be exercising directly right after administration of insulin. They should wait to monitor the effect of that. They should have high protein and carbohydrate snacks with them, and glucose tablets ready and available if needed. It's not listed here, but they should really be notifying somebody, a friend or a coach or a teacher, and letting them know that they're diabetic and having their emergency bracelet on. And they can feel free then or safe to exercise when the glucose level is between 80 and 250. The next two bullets just talk about types of exercise that's best. Low intensity for longer periods, of course, such as walking, biking, or swimming, and high intensity for a shorter amount of times. Okay, so goals of treatments, just to review one more time, and I know you've heard this all last semester, but it's a good review, is that the hemoglobin A1C should be less than 7%, and again, the hemoglobin A1C is measuring the blood sugar control over the last, say, 3 months or so. The fasting blood sugar and pre-meal blood sugar should be targeted between 80 and 120, and bedtime blood sugars around 100 to 140. And of course, the lipid panels, including the triglycerides, HDLs and LDLs should be within normal limits. So that is really the ideal goal of treatment. I would encourage you again to review through your notes from Health Alterations. We will be looking in this learning plan at some very new stuff, including adrenal, thyroid, pituitary disorders. So this is kind of a nice review of diabetes. If you have any questions, please give me a call. Thanks.